Yes, thank you very much for your kind introduction, and good afternoon, ladies and gentlemen. So I will talk mainly about the product of Cologne, the basic symptom approach, which was already introduced by Professor Maggini, who translated, by the way, as I very well know, the basic symptom scale into Italian. Well, when we start to talk about predicting psychosis, we have to remind that the special thing of psychotic disorders, and especially schizophrenia, is that there's really this prodromal phase that makes it much easier than for any other psychiatric disorder, where it is really difficult to identify that. And that is not something which we invented. This was already described by Kraepelin and others. So the Anglo-American approach, the ultra-high-risk approach, tried to define an immediate risk. So to predict what happens in the next 12 to 24 months in order to have a good starting point for an intervention. The German tradition started earlier with the basic symptoms because we saw that the onset of functional decline precedes the onset of the first attenuated psychotic symptoms or similar phenomena by years. And the basic symptom concept, which was already mentioned, what is the definition? Well, basic symptoms are subtle, subclinical disturbances in many domains, and the most important are thinking, speech, and perception. The special aspect is that it remains predominantly in the perception of the affected person, so it's more or less a subjective experience. Persons can deal with it, and they are always and immediately recognize that this is a disturbance of his or her own mental process or perception. So you have to ask them, is something wrong with your hearing or with your vision or something like this to get that. So ZAPS was the original instrument. Meanwhile, it was further developed and shortened to the schizophrenia proneness instrument, the adult version and the child and youth version, which, and that is also a special feature which is published in Italy by Fioriti. So you can get it there. The idea, and that is something which brings the basic symptoms in the central interest of neurobiology, and that's my also most interesting point here, is that the concept by Huber said, well, there are pathological cerebral dispositions which lead to disturbances of information processing, first on a neurobiological level, on a neurocognitive level, and then these disturbances come to the mind of the person first, and that are the basic symptoms. So in a way, basic symptoms are called like this because they are so close to the substrate, the neurobiological substrate of the disorder. And on the other hand, they are the basis also of the development of delusions and hallucinations, which were in this concept only epiphenomena, which interestingly is a conversion with the concepts of people like Bentel or Morrison, or also Kapur's model, that delusions and especially delusions are a more or less dysfunctional coping behavior. So the predictive validity was first shown in a study with a mean follow-up of 9.6 years by Joachim Klosterkötter and Frauke Schulze-Luther, And the transition rate here was 70% over this time. And that was also 70% into schizophrenia, not just psychosis. And when they looked for a special set of symptoms, they identified these cognitive perceptive basic symptoms. When one of 10 of these basic symptoms was positive, the 3 years transition rate was 50%. When none of these symptoms was positive, it was just 13%. So that already showed that this approach is really helpful for a valid prediction. It's really not that easy to use. So we replicated these results in a second study, which is also the empirical basis for the schizophrenia prognose instrument, where we again showed that within a follow-up period of, on average, 20 months, the total transition rate was about 35%. 24 months, it was 33%. So this approach worked very well, and Paolo Fusapoli published a nice meta-analysis about the outcome in terms of categorical diagnosis in schizophrenia bulletin. And what I want to show you is that if basic symptoms were the inclusion criteria into these studies, so basic symptoms were definitely present in the samples, the relative risk was about 17. If it was only the UHR criteria, it was about 4 to get a non-affective psychosis, and the non-affective psychoses were mainly schizophrenia. So it seems, and for me that makes very good sense, that the presence of cognitive and perceptive disturbances, which we think are at the core of schizophrenia, also better predict schizophrenia than just a phenomenon like mistrust or something like that. Last year we did a meta-analysis for the guidance project of the European Psychiatric Association, which was published in European Psychiatry and included about 45 studies with about 5,000 subjects, and looked again what about the transition rates. Here you see the rates for those studies who included the samples by the UHR criteria, regardless of basic symptoms. And the 3 years rate was about 30%, and the 4 years rate, or more than 4 years rate, about 37%. If you do the same with the basic symptoms, so inclusion by basic symptoms, regardless of the presence of UHR criteria, it goes up to 61%, which again shows that this adds a predictive validity. Oh, that's easier. And if you look for the single symptoms, you see here the transition rates within 2 years with the UHR criteria about 19%. But if UHR are combined with the cognitive, it goes up to 20.27%. And we analyzed that for in a follow-up study from the first 5 years of the Early Recognition Center in Cologne, the FETZ, and found the same, that with the cognitive, so a cognitive disturbances cluster of the basic symptoms, the 4 years rate was about 23%. If only cognitive were present at the beginning, if only UHR criteria were present at the beginning, it was about 28%. But if both were already beginning at baseline, it raised to 66% within 4 years. So that is also another approach, of course, for risk stratification and enrichment in studies for testing a preventive approach. What we are also interested in is the effect of age. There is some heterogeneity in all these samples across the world, but not really good analyzed aspect is that they differ in their age structure, sometimes heavily. So the most European studies have only adults, so study from Cologne or the studies from Basel have only adult people, because we have this separation between adult psychiatry and child and youth psychiatry, whereas the Australian or the American samples are more mixed. So if you look at this factor, you see that after 2 years we had this 19.4% transition rate. If we look now for just 18 as the limit, then it went up to 24%, but what is more important, it goes down to 10% in the adolescents. And that means clearly that our criteria do not mean the same in young people and young adolescents as in older adolescents and young adults. Obviously, if these symptoms are still present at older ages, they become more predictive, but they may be more or less a variance of normal experiences if you are 12 or 14 years old. And the recommendation from that by the EPA was, for those who are interested in that, that the genetically increased risk plus functional decline criterion may have to be dropped because it does not really separate anything. And the other approach, which we used in the European Prediction of Psychosis study, was to find a way to overcome the problem that if you get more specificity, you always lose sensitivity. So to demonstrate that, that is the transition rate from EPOS after 18 months, about 19%. If we now have the problem that we want to raise this rate, then we have to narrow the criteria. That is the classical way. You narrow the criteria, but then what you do is that you lose all these people which may have a benefit from a preventive approach. That is the cost of higher specificity, that you lose sensitivity. What we did is that we identified a set of six predictor variables from the EPOS clinical data set, and we used that. Normally, if you see publications, they stop here. They present you this set of variables and say, well, that was the set of significant variables, fine. But it doesn't make use of this table because that is a regression equation. It is derived from Cox regression analysis, and what you see here is nothing else than an equation. And you can use it. You can use it to calculate individual prognostic scores. That is something which is done in oncology and other somatic medicine areas since years. And what we produced with that is a 4-class risk index, a prognostic index which ranged from 3.5% transition rate to 85.1%. And I think that's a huge difference. So the 19% were separated in 4 classes, and now you see the full range. And that is, of course, a step to an individualized prediction of psychosis. And then you don't have to lose anybody, but you can give anybody a prognostic score, and you can, of course, follow that up over time and look dynamically if it changes and can target, and that is, of course, the aim behind that, so can in the future may be able to target your interventions to the needs of this person at a given point in his risk period. And if we look again for this COCDIS-UHR combination, in the highest risk class, nearly 83% showed this combination. We did the same analysis also for the prevention studies, and came out with a result which resembled another publication by Mark van der Gaag, that we had, after 12 months, an average risk reduction of 56% and a number needed to treat of 15. For those who are not so familiar with this, measure if you need to treat 15 people that for having one who has a benefit from that. If you think that that are many people, you need to treat about 37 to 70 people with aspirin to have one who will not get a stroke after 2 years. So 15 is a really good number. And in the 24 to 48 months period, the average risk reduction was still 42%. Here's an example from Cologne for a psychotherapeutic trial. And you could see that with this combined psychotherapeutic approach, the 24 months transition rate was 3.2%, and with a supportive counseling, it was about 15%. I show you that to demonstrate that it is possible to intervene in this high-risk period also with cognitive behavioral therapy, which was used here. And that is also the result of the meta-analysis. If you put all the CBT trials together and the medication trials together and look for the 1 year rates, because that are the most robust due to the studies behind that, then you see that there is no difference between the psychotherapies and the psychopharmacological approaches, which led us to the recommendation that in adult patients there should be a staged intervention model where you start with CBT, and if the CBT is not effective, you can complement it with low-dose second-generation antipsychotics, but with the aim to achieve a degree of symptomatic stabilization where you can start again with the psychotherapy. Unfortunately, there is no effect of all these interventions on functioning. Well, one has to say, a word of caution, these studies were not designed to influence functioning. And the measures used in the studies was also not the most optimal to measure functioning, because the whole focus in this time was on transition to psychosis and not on functioning. So that has to be reanalyzed in newer studies, but nevertheless, we have this good effect on transition, but not on functioning. And that is important because we saw in the EPOS study, the same is true for the North American studies, that we have about 30 to 40% who have a complete remission of the symptoms which indicate an increased risk, but still have completely deteriorated functioning with GAF scores around 40 or 50. So that is something which shows that which is for us most challenging in schizophrenia, the functional loss, starts early and perhaps goes on afterwards. And we have to find ways, of course, to intervene with the focus on functioning. One way to do that may be social cognition. We meanwhile know, especially this paper by Green is very interesting, that social cognitive deficits are already present in the clinical high-risk state. And from the EPOS data, we also showed that a deterioration of social functioning is predictive of transition to psychosis. And I think in that it is not just an indicator like the symptoms, it's perhaps a factor which drives you more and more into this direction, because you get more and more away from social relationships and lose reality testing and so on. So we have to do something, and that's a future direction. In this March, we start a new study in Germany, a multi-center study, where we will compare two conditions: a multimodal preventive psychological intervention, where 50% of the 22 sessions are focused on social cognitive abilities, and the comparison is an acetylcysteine, which is thought to be neuroprotective and glutamatergic and anti-inflammatory. So that is really a well-known drug. We use it normally for cough. but it is, in terms of neuroscience, it's a real high-tech drug. It's fascinating what results during the last 2 or 3 years came up from animal studies for this compound. So we are very interested to see. Well, what can we do next? Promising neurocognitive, neurobiological candidates are neuropsychological tests. Predictor statistics have been shown for processing speed, for especially neurophysiology. And I saw a poster by Professor Altamura also, who found something like what was shown here for the QEEG in family members of schizophrenia patients and brain imaging. Just to show you on the processing speed trial, where we could find that APS plus cognitis, again the combination, plus a deficit in processing speed allowed a very good prediction, and also a stratification into different risk class with a very high risk in the highest risk class, and a shortening of time. And that is the other thing which is interesting. Not just look at the transition rates, look also at the times to transition, because that is something which we can clinically not really get into grip. Now we can say, well, this is a transition, but we do not know when we see the patient for the first time. Is he at the end of this period, at the beginning? And my position is that the neurobiological parameters, including the neurocognitive, may give us a chance to better determine the position of this person in his individual prodromal phase, which of course varies also from person to person. So, and that is why I say, well, it's not only the rate which is interesting, but also the time to transition, which is shorter here. And the same was possible to show with the mismatch negativity, where we could also differentiate a class with an 85% transition rate and one with a 34% transition rate. But especially we had also a difference in the time to conversion. And if you see the confidential intervals here, they do not overlap. And that is, of course, really fine. If a statistician sees something like that, he says, well, you do not have to test anymore, you know what happens here. And that is robust. Could also be shown in a meta-analysis, which is in press in biological psychiatry, where we saw that over all these studies, there is really an effect of the mismatch negativity. What we are doing right now, together with Anita Riecher and Paolo Brambilla, who are also in the audience, is the PRONIA study. It's funded by the EU and coordinated by Nikos Koutouleros from Munich, where we try to put together all these different levels in one major tool, and perhaps in the next years we will be able to report results from this approach. Well, let me end with some conceptual considerations. We have a problem in all our studies until now, that we have a baseline and then we have a follow-up period of 1 year or 2 years or 3 years. But what we are doing is that we identify the baseline variables and then we assume that nothing happens anymore until 2 years later, that there is a linear relationship between baseline and 2 years later, because we do not have the data about that, what happens there. And the new studies now start to look for that, because if you look only at the baseline, you cannot see what happened in between. The people may move from we heard that from Jim van Os, from a bad environment with a stressful neighborhood to a very nice environment with a very nice neighborhood, and their risk will of course drop. But you cannot see that. You only see, well, some people go into psychosis, some not. But we do not know about the mechanisms which really differentiate between them. And I think one thing is that we need to look for the interaction, not only of the risk factors with the environment, but also of the protective factors. So resilience is an important term here. And I think Jim van Os showed you a model where he said, well, we have to see the genes on the one hand, the biology and the environment on the other hand. But we also have to look for the individual condition of this adolescence. Coping behavior, what did he learn about the world, and so on, which may bring him in a more risky or in a more protected state. So he may show the same risk symptoms, but he may be able to better cope with that, and that means that he may be able not to transit within the 1 or 2 years we are able to observe in our too short, and that is my endpoint, too short follow-up periods. Stummer wie und